All right, my friends, let's do part two of our study on how much your medical out-of-pocket expenditures will be in retirement. This is going to be the second part of the study from the Center for Retirement Research over at Boston College that talks about that. So now we're going to talk about the literature review and how they came up with their assessment on your out-of-pocket expenditures, excluding long-term care. Just got back. You might see my face a little bit red. Just got back from mowing the yard. 25 degrees outside. Get your hat on. Woo! It's good. And I tell you, one thing about living in the South, you get a little bit cold. It gets you fired up and ready to do stuff. I do miss that about being in the North for a little bit. And then after about 3 months' time, no more. All right, so literature review. This project builds on several previous studies examining the out-of-pocket burden on retirees. Kubanski is going to use a Medicare Current Beneficiary Survey, MCBS, from 2000-2010, which shows that out-of-pocket spending, OOP, out-of-pocket, spending rises with age and health needs. Who knew? And that the premiums comprise a large share of the out-of-pocket spending for Medicare enrollees. Kubanski et al. Used a consumer expenditure survey from 2012 on forward to show that healthcare spending comprised about 14% of total spending for households with Medicare enrollee. Interesting, huh? Because that's exactly what the CES is. About 12 to 15% on any, depending on what cohort you are, 55 to 64, 65 to 74, 74 to and beyond. Noel Miller, 2015, uses the 2011 MCBS to quantify out-of-pocket costs for seniors enrolled in traditional Medicare and finds that the out-of-pocket burden is highest among those near poor who do not qualify for Medicaid. Interesting. They document a modest decline in out-of-pocket spending after the introduction of Part D. Medicare enrollees spend 1.4 percentage points less of their income of out-of-pocket expenses in 2010 than in 2000, and find the bulk reflects the reduction in spending on prescription drugs because George Bush passed the Medicare Part D part in 2005, I believe, or three or five, something like that. So isn't that interesting, though? So that's okay. So again, we're using the idea how much your out-of-pocket expenditures are, and there's not as much as might think relative to other things. However, the near poor who do not qualify for Medicaid are the ones who get the shackles here for sure. So we got the poor, and I've always noticed this actually in my whole life. The poor get a free ride to Harvard. The rich, they don't need free rides because they're rich. It's the middle and lower middle classes that always bear the burden of over government spending to focus on the poor and the tax consequence of the rich. It's always the near poor, the working class, the lower middle class. And that does take me off. And going back to the other video I did, which showed you that Medicaid recipients have a higher percentage of their Social Security left after including Medicare costs or out-of-pocket medical expenses. I'm telling you, from a political perspective, there's a huge segment of the population that is ripe. That probably voted for Obama twice and Trump once. And if I were on if I were a political party, i.e. the party that I would support, which is the Republicans more than the Democrats, it's going to be awful tough to get me. I mean, look, I don't support the Republicans very much anymore. I don't see a Democrat out there. I mean, what was the guy from Ohio? There's a traffic count. That was probably the last Democrat that could even, I don't know who else it could be. But if I were a Republican and I wanted to own Medicare and Social Security issue for a generation, I'd be going after those group of people right there and say, look, you worked your tail off. We're going to make sure that you are not poorer because of work. The idea that you're poorer relative to Medicaid recipients is nuts. And we're going to make sure that does not happen. And I'd be attacking that like white on rice because there's a huge segment of the population that's working class people. They work their fair 40. They punch the clock for 40 hours a week. They're getting up and they're saying, man, we have the most expenditures, out-of-pocket expenditures relative to retirement income than anybody else by far, to include those people who do not work. It's not right, man. There's huge opportunity there. But that's the Republicans are called the stupid party for a reason. They don't see it. Their corporate donors in the Chamber of Commerce, the National Chamber of Commerce, tells them to jump, and they say how high, and that's it's actually quite frustrating. The Main Street versus Wall Street mentality is alive and well amongst many voters still, though, and the Main Street are the voters. The money's the Wall Street. The Main Street's the voters, and you need the voters. So hear me, because if I were a political advocate, I would see that as an opportunity that's willing, ready, and able to be taken, and will follow you. This study finds that cost sharing burdens as a share of Social Security income, especially for lower income Medicare enrollees are expected to grow in the future. Exactly. So more and more of their benefits are going to be taken away due to the Medicare out-of-pocket expenditures. Again, you got the poor over here, you got the rich over here. You got the middle and upper middle classes probably getting by fine. Is that segment of the population that I'm telling you right now, man. Let's see. By 2014, I don't care about that. Donut hole. In addition to more recent data available, the HRS, the Health and Retirement Survey, offers two other advantages over the MCBS. So the previous Medicare spending survey we don't use anymore. We're using the HRS. First, the detailed data in the HRS enabled the project to consider Social Security income separately. OASI is Social Security income, which allows for the examination of Social Security benefit adequacy. Second, with the HRS data, the project can include reliable information on the Medicare Advantage enrollees. In 2014, 30% of Medicare enrollees were participating in Part C, which is up from 14% in 2002. Now, Obama really was trying to put the screws on Medicare Advantage, and it didn't work. It went the exact opposite. So that's interesting. We'll see how that shakes out. Look, I'm in favor of that for sure. More options are better, but we shall see how that shakes out in the long run. I don't know. But my default is Medigap or Medicare supplemental policy because, again, if a doc takes original Medicare, they will take you. You're in network for any doc who takes original Medicare, which is Part A and Part B. So now it's crucial to include this group. Previous analyses relied on the MCBS, which lacks reliable information on out-of-pocket spending by Medicare Advantage enrollees. The project is also similar in spirit to the Medicare Trustees Report. The trustees quantify the average portion of care covered under Medicare Part B, the physicians and outpatient, and Part D, prescription drugs. Remember, Part A is your HI, your hospital insurance. So there is really no out-of-pocket expenses. I think that $185 a year is your deductible there. So Part A is what you pay for under your OASDIHI. That's your hospital insurance. That's part of your FICA. You don't pay that anymore except for a small deductible when you hit retirement. Now, but you're still paying your Part B premiums because you never paid the Part B under FICA. The trustees project the program costs of Part B and D through 2090 and forecast the rising costs of Medicare's Part B and D for the insured will outpace the increases in Social Security benefits. I 100% agree with that. The out-of-pocket measure used in the current investigation expands upon the one used by the trustees to include all non-long-term care costs borne by Medicare beneficiaries, which include out-of-pocket spending on hospital care, usually covered under Part A, but with substantial cost sharing. If you don't have a supplement or you don't have Medicare Advantage, you have 20% is still going to be on the hook. That's the drawback by original Medicare. Why you need a supplemental policy. They're going to pay 80, you're going to pay 20. That's the cost sharing. So you got to get a supplement. I mean, you don't have to, but you should. And other uncovered health expenses that eat into Social Security income. The project also constructs an alternative measure of out-of-pocket expenses that does include long-term care costs. The analysis also accounts for supplemental insurance for Medicaid, Medicare Advantage, retirement health insurance. Again, no Medigap is odd. Importantly, the project uses individual level data rather than average measures. I like individual, don't like average. The individual data allow for addressing questions such as whether medical costs comprise a larger share of Social Security benefits for the near poor who do not qualify for Medicaid but have a difficult time purchasing supplemental insurance, and whether benefit adequacy is a bigger problem with seniors with most health conditions or for the oldest of the old. Okay. So that's the literature review. So let's look at data methodology here. So let's take a pause for just 1 second. Data methodology. The study uses data from the 2002 through 2014 waves of the health and retirement study. Since its start in 92, the HRS has collected information every 2 years on the financial security, work histories, medical expenditures, insurance covers, and self-reported benefits of Social Security of respondents who are at least 50 years old. Let's see here. This sample is limited to retirees fully detached from the labor force who are choosing health insurance from among Medicare and the supplemental plans and not from employer-sponsored health insurance. So solely people absolutely removed from their employer for income and for health insurance as well. The three components of the study are Social Security benefits, total household income, and out-of-pocket medical expenditures, excluding long-term care. That's what we're going to analyze in the next video when we look at the results. Those three components are derived from self-reported information in core health retirement study, but do require some adjustment. In the case of Social Security income, survey respondents were asked to report their monthly amount net of Medicare deductions. To back out their gross Social Security income, the analysis adds in their Medicare Part B premiums. The HRS does not collect information on Medicare Part B premiums, but the analysis adds a nationwide Part B, which is $135. All right, plus premium surcharges from IRMA, the income with respect to Medicare, whatever. If you make too much money, pay more for your Medicare Part B. The total, which should represent the gross Social Security benefit, was then indexed to $2,014. The top coded at $50,000. I don't know what that means, but okay, so $2,014. This study, therefore, also examines the percentage of total income, Social Security benefits, as well as income from other sources such as pensions, government transfers, and capital income, and income from 401k plans and IRAs that remains after spending on medical costs. Let me just go down to number 11 here. I'll make sure they're not using the CPS because we talked about the CPS, the Consumer Survey, Consumer Population Survey from the Census Bureau that was lacking. Total personal income, unemployment, the respondent is married or in marriage-like. Okay. All right, so don't say about calculate from the RAND Corporation. Okay, good. All right, so let's see what else. You see some of the data there. Because cost sharing in traditional Medicare can be substantial, most beneficiaries have some form of supplemental insurance coverage, Part C or Medigap. These supplemental plans differ considerably in their out-of-pocket costs, so results are reported separately for each insurance category. Respondents are assigned to the other insurance category if they are covered under CHIMP, TRICARE, Medigap, long-term care insurance, and other private plans. So that's where the Medigap comes in. The TRICARE it's on another other category other than the top three, which is Medicaid, Medicare Advantage, and RHI, which is retirement health insurance. All right. Good. So that's it. So that's all I want to talk about. We talked about the literature review, the data methodology, and now we're going to do another video on the results. And this is where it's going to get interesting. So we laid you the groundwork on the first video of this three-part series. Laid you how they found the data and the methodology and the literature review of this, and now we're going to get the results of their study. So stay tuned. We'll see you here in just a bit.